Hello, I'm Cheryl McCarthy of the City University of New York. Welcome to One-to-One. In the 1860s, New York City had some of the worst health statistics in the nation. Crowded tenements, filthy streets, and unsanitary conditions all around contributed to an annual death rate of 1 out of every 36 residents, according to the Living City Archive. Enter the Floating Hospital, an initiative by private citizens which purchased a succession of ships that took poor children and their mothers for daily rides around New York Harbor, exposing them to fresh air and sunlight, giving them fresh milk, and providing a staff of doctors, dentists, and social workers to attend to their health care needs and provide nutrition education. The Floating Hospital no longer floats in the literal sense, but with its main clinic in Long Island City and 6 satellite clinics, it continues to bring health care to some of the city's neediest residents, and their needs may be greater than ever. Today, we're talking with Dr. Shani Andre, Vice President and Chief Medical Officer of the Floating Hospital. Welcome.
Thank you for having me.
So tell me about how the Floating Hospital got started.
It basically got started to serve the needs of those child laborers in New York City. It's the city's oldest pediatric hospital. Next year will be our 150th anniversary. And it basically originated to take out those child laborers, to get them out of the city, to expose them to fresh air, clear out their lungs, provide health education to them and to their parents, and try and, just expose them to the kind of first version of the Fresh Air Fund, basically, on a boat.
How did those trips work? I mean, where the ships picked up people? Were they on the ship for a day? Was there one ship a day, several sailings a day? How many people?
Typically, it was one kind of sailing a day that they went out from. Most of our piers have been kind of on the lower west side of the city, traditionally, and they went out over the course of the summers. And then as it progressed over the years and they started to see more of a need, going from 1866 when we started up until the early 90s, then we started providing services basically year-round. But up until that point, it had been mainly summer sailing programs.
Okay. So in the wintertime, it didn't sail, but it provided services off of the ship?
On the ship.
Oh, okay. Okay. Did the people who came, the mothers and their children, did they have to be certified as poor by a church or some agency, or was it for any mother or child who showed up?
At that point in time, it was anyone who wanted to provide and wanted to receive the services, and they were able to come. That's evolved over the course of the years, but initially it was whoever needed services at that point in time, and there was no need to kind of qualify for those.
Okay, because there were a lot of poor people in New York.
Yes.
Once they were on board, what happened?
They had medical providers who would do physical exams. We had dentists, which it's hard for me to imagine doing dentistry on a moving boat. But they had dentists that provided services.
Okay.
They had health educators. They had nutrition counselors. So they would have different health education topics. They had entertainment also. So they wanted this also not to just be solely based on the medical, but also to provide a little bit of entertainment. So they had different entertainers, musicians, clowns, different activities to kind of keep the kids involved, while parents went off and did kind of other topics and trainings for them in terms of healthy eating and behaviors.
Okay. And there was something called the Seaside Hospital?
Yes. So that was originally one of our kind of partner hospitals that we worked with. And so if patients required, additional kind of inpatient stays or additional services that they couldn't provide on the boat, we contracted with that hospital and they provided services for the residents.
Okay. So they would be admitted to the hospital, and that was on Staten Island.
Correct.
Okay. And all of this was free?
All of it was free.
Okay. I would assume that these were mostly immigrants.
Initially, yes. So that was a large population, a large percentage of our population when we first started out, and that has evolved. We still target low-income families. Much smaller percentage are immigrants, but we see that needy population continuing to grow.
Right. Talk about and I alluded to this, the health conditions in the city at the time. I'm sure dark, crowded tenements. Little light, poor ventilation, inadequate sewage system, human waste thrown into the street, and not to mention the horse droppings. Right. What would have been some of the diseases at that time? What are you talking about?
We saw a lot of vitamin deficiency anemias, iron deficiency anemias, things like scurvy, things that we don't really see or kind of imagine today. A lot of pulmonary problems, so a lot of respiratory problems, and that was kind of how the sailings took place, is getting them out of those crowded, poor kind of ventilated conditions and exposing them to fresh salt water and fresh air to kind of clear out their lungs. So a lot of respiratory problems and a lot of kind of nutritional problems.
Okay. So how did the services, or did they, change over the years?
I think the services changed as the target population changed, and we were developed and founded as a charity hospital, and that still continues to be our mission. We are a nonprofit, but at our core, we really are a charity hospital. And so as we saw, luckily, child labor laws come into effect, and we saw populations of child laborers basically become non-existent, we still continue to target those neediest families and those neediest populations in New York City. And today, it's currently evolved to those homeless families in New York City, which continue to be a growing population.
Now, at some point, the ship sailed for many years, and at some point in the 80s and 90s, it was bouncing between a couple of piers in the East River, and after 9/11, it no longer made the daily trips.
Correct. We lost our pier space with 9/11 because they needed it basically for cleanup reasons. And so the barge was dry docked on the east side, and we tried to find a couple of different spaces for it, and nothing really worked out in terms of ideal locations for what we wanted as a healthcare provider and what the city was able to provide.
Right.
And so we made a decision at that point to go completely land-based. Prior to that, we'd started opening some land-based clinics, realizing that the numbers and the volume of patients that we needed to serve was expanding and we needed other resources. But after 9/11, we basically made the decision to go completely land-based.
Okay. I think I read that your ships, and there were various ships at various times, I think I read that you carried 5 million passengers over the years?
Over the course of the years, yes.
Okay. So now you have, tell me your setup currently.
So currently our main clinic is located in Long Island City. And out of that main clinic, we serve about 200 different homeless family shelters and domestic violence shelters. And we have 11 vans. So we operate 15 passenger vans. And so we send these vans out to all of the boroughs, including Staten Island still, to pick up clients from domestic violence and homeless family shelters and bring them to our main clinic for services.
Okay.
One of the biggest populations in homeless family shelters are kids. So 40% of the homeless patients that are housed on a daily basis in family shelters are kids. And so what we typically see are lots of young moms with kids. And so if I'm a mom with 3 kids, trying to get my 3 kids, 2 are in a stroller, 1 is toddling, trying to get all of us to a medical provider proves difficult in the New York City subway system because not every station is, handicap accessible. You've got strollers and diaper bags and toys. So we operate our vans as a way to go directly to the shelters, pick those patients up, and then bring them to our clinics. So we try and eliminate transportation as a barrier to health care for these families.
Are you the primary provider of medical services to people who live in the city shelters?
No, there's several providers that provide medical services to homeless families. We all kind of contract with different shelters and have different relationships with shelters, but we're not the only one.
Okay. So what kinds of medical services are we talking about?
So our focus is kind of primary care and primary health for families. So we provide medical services and everything that's covered under the scope of primary health care. We also provide dental care for adults and kids. We provide mental health and psychiatric services for adults and kids. And then we have some kind of subspecialty care that we're trying to branch out into. We have a cardiologist currently, and we're looking at some other subspecialties like dental and podiatry that have seemed to be high volume areas of need for our patients.
Okay. How many doctors, nurse practitioners are we talking about altogether?
Altogether, I would say we have, in total, kind of all of our services, we have about 180 staff members on staff, and that's including our medical assistants who do our initial triage and evaluations of patients, our licensed practical nurses who do vaccines, we have our registration specialists, so kind of the whole team is comprised of about 180 staff members.
And you actually have a clinic that is at a housing project,
yes,
correct?
In Queensbridge Public Housing in Long Island City. It's the largest public housing in North America, and so we have a clinic that's located directly within the confines of that public housing to serve those needs of those residents.
Now you're located, do you also serve other boroughs, or are you primarily focused on Queens?
Every borough.
Really?
So we
Okay.
pick up from Staten Island, Bronx, Brooklyn, Manhattan every day.
Are these walk-in clinics, or how does it work?
They operate on a dual setup. So we have patients who have scheduled appointments, and then we have patients that if we get to the shelter and there's a new family that has a need and we have space on the van, we take them at that point in time, or we send a second van back to pick them up. Patients also kind of have learned where we are, and so they can walk in. If they want to take the train on their own and come in for services, they can do that.
Are the services free? Are we talking about Medicaid with a range of prices? How does
So
that
for
work?
our clinics that serve the homeless populations, that's the biggest part of our charity care. And so in those clinics, we basically don't collect any payments. So if patients have copays, we don't collect those. If they have deductibles, we don't collect those. About 80% at this point in time of those patients, actually 75% of those patients at this time have insurance. Whether it's Medicaid managed care, we have a small population that have Medicare, a small population that have commercial insurance, which are typically those families that are we're seeing that are in a domestic violence situation. So for those patients, we bill their insurance. For those patients that are uninsured, we don't collect any payments, we don't send bills, we don't worry about those. That's part of the charity care that we provide. Under our scope as a federally qualified health center, we also have community health centers. And so in those community health centers, for those patients that are uninsured, we operate a sliding fee scale. So based on their income level, the number of dependents in their household, they get a discount off of what the full rate of pay would be, so that it's a nominal charge for them to receive services with us.
Do your staffers ever go to the shelters and safe houses, or is it all they come to you?
4 of our clinics are located actually within homeless family shelters.
Oh, really?
And so those clinics service the needs of those residents directly at those shelters. Typically, they're 200 to 300 family shelters, and so all of those services, most of those services are provided on site. Things like our dentists, they have to come to our main clinic. For the cardiologist, they come to our main clinic. But the majority of the services are provided on site for those residents.
Okay. How do you, and I know that there are many different kinds of health networks in New York City. Who finances this? I mean, is it mainly federal money from Medicaid and Medicare? Are there additional state, city monies? Where does the money come from?
We have a kind of a combination of things. So as a federally qualified health center, we do receive federal funds from HRSA. We have our patient revenue services. So for those patients that have Medicaid and managed care, we bill Medicaid for those services, and so we receive funds from those. We do fundraising. So we have an annual event every year, and then throughout the course of the year, we look for different grants. So our health education department, that's a service that's not reimbursable by Medicaid. But we provide those services because we understand how valuable they are to educating the parents, educating kids about different things. And so most of those services are typically funded by private foundation grants. And so we look for different things. So it's a mix of things that go into how we stay afloat.
Okay. We're going to take a short break. Then we'll be back with more with Dr. Shani Andre of the Floating Hospital after this message. Welcome back to One to One. I'm Cheryl McCarthy of the City University of New York, and I'm talking with Dr. Shani Andre, Vice President and Chief Medical Officer of the Floating Hospital. We were talking about how your programs are financed. I'm just wondering, has the Affordable Care Act had any kind of impact either on your clients or on your programs?
It has, and in a positive way. I would say what we saw 2 or 3 years ago was that our number of uninsured population was about 30 to 35%.
That's your number of
uninsured clients.
I see.
We're about 30 to 35% of our total population. We've seen that number go down to about 20% at this point in time. So what we saw was more clients were Medicaid eligible. For those clients that were kind of the working poor that were unable to kind of qualify for insurance through their employer, were able to get insurance exchange products. And at this point in time, of the 20% that still remain insured, most of them are undocumented. And so we still kind of struggle with what is the solution to that population. As of now, there's not one. So for our homeless patients that are undocumented, we continue to provide them care, and we look for other funds, other grant funds, using the Medicaid revenue from our other services that we bill to kind of offset those costs.
Well, the people who were uninsured before, would they still be able to get services through your clinics, or would they have to go to emergency rooms? How did that work?
They can still receive services with us.
Okay.
We have seen the need to kind of increase our provider staffing, so we've seen an increase in volume of patients that we see.
Right.
So over the past 2 years, we've been trying to ramp up staffing. We operate in a model because we see families where we like to staff either family practice doctors or internal medicine, pediatric doctors, and family nurse practitioners, because that way the provider can see the whole family as a unit,
right,
as opposed to the kids having to see a pediatrician and the mom having to see an internist. Because what we find is the moms have a laundry list of priorities, and their own healthcare typically ends up being low on the list.
Right.
So they'll wait for the kids to see the pediatrician, but they may skip their own visits. But by seeing the unit as a family and treating them all together with one provider, everybody can have their needs addressed all at the same time.
Mm-hmm. And it also means that when they are insured, then you can get reimbursed. You don't have to go out and raise more money to pay for their care. Correct. On your own.
Correct.
Okay. How many patients would you see on a given day or in a given year?
In a given year, we see about 17,000 patients, about 65,000 visits across all of our sites.
Okay. What are some of the biggest health issues that you're dealing with these days, and has that changed?
It hasn't radically changed probably over the past 10 to 15 years. We still see a lot of kind of what we would call primary preventable issues related to obesity. Poor diet, poor nutrition. Again, we're talking about families who are disenfranchised. They're in homeless shelters, not the greatest conditions. You may have 5 or 6 people living in one apartment together. They don't necessarily have kitchens. They don't necessarily have refrigerators. So their diets may not be the best. So we see lots of obesity, and then we see the sequela of that in diabetes and hypertension. All of those things continue to be an issue on the rise.
Right. You mentioned that you do offer mental health services.
Yes.
I would certainly... that's an issue for the general population, but I would think especially when you are dealing with people who in shelters who have left violent situations, and also families who are dealing with protracted homelessness, yes, or recent homelessness,
yes,
there would be mental health issues that you would, yes, have to deal with.
Definitely. We see lots of anxiety issues, depression, PTSD that you see in this population, especially with our women and kids even who have been in domestic violence situations. And so you see kids who see this pattern of violence, and so that begins to become traumatic for them, and so they then begin to act out. And so we love our team of kind of child and adult psychologists, because again, they do family sessions, because things that are affecting mom have rolled down and affected, right, the kids. And so doing family sessions a lot of times can help, bring those issues out and help the whole family unit. And
you would have enough therapists to offer people who needed weekly visits?
I would say probably 50 to 60% of our clients come in for weekly therapy, okay, sessions. Probably a smaller percentage are seen by our psychiatrists, so there's the med management component of the therapy, but we have psychiatrists, child and adult psychiatrists on staff, right, to provide those services.
Right. Tell me about your history, okay, and how you got interested in medicine and in pediatrics, and how you wound up at the Floating Hospital.
I always say that my parents brainwashed me to become a doctor. From when as young as I remember, I always said I wanted to be a pediatrician. And so that was kind of the path that I was set out on, and my scope of practice changed. I always loved kids, and so I kept that in there. I'm internal medicine and pediatrics trained, so I can see both adults and kids. And I ended up in New York because I love the city. Mm-hmm. I did my residency at St. Vincent's, which no longer exists in the Village. And one of the prior residents had come on board with the Floating Hospital, and I got introduced to him and came in for an interview and loved the mission of the organization and loved the services and the work that they were doing. And I started as a provider with, right, the organization, seeing patients in our Long Island City clinic not long after we opened there. And then as an organization, we started growing and developing, and we took on a contract with what was the Department of Juvenile Justice. And they needed a medical director for that contract. And so I assumed the role as the medical director for that contract for about a year and a half.
Were these young people who were in the juvenile justice system?
Who are coming through the juvenile justice system. And so we still operate that contract. It's with the Administration for Children's Services now.
Okay.
But they have 2 secure detention facilities, one in the Bronx and one in Brooklyn.
And you worked at those?
I worked at those and oversaw all of the care. So we provide 24/7 medical care for those residents that are there in those facilities. And then there are smaller group homes and those kids that are non-secure group homes that we also provide their medical care and their dental services.
Mm-hmm.
So we provide those on site. And then in 2009, we got a federal grant from HRSA to open up a community health center in Long Island City to service Northwest Queens. And so I transitioned into that role of opening that community health center up and getting it up and running and servicing the community. And in 2010, I became chief medical officer.
Okay.
So I've been in this role now of overseeing kind of all of the clinical aspects of what we do as an organization.
You talked about how you try to get doctors who are in family practice and internal medicine. And my impression is that those are the areas you have fewer doctors going into the everybody wants to be. I don't know what they want to be. I hear dermatology is big. I don't know why.
There's a high need and it pays well. So,
okay.
And that's typically with most of the subspecialties. They are more glamorous than traditional family practice.
Right.
But that's the core of what all of our patients need. You know, what we see a lot of times is, you know, the lack of primary health education, primary preventative care. So a lot of these things that end up with a subspecialist, if we had more of those primary care providers targeting the education,
you wouldn't have those.
We could potentially decrease a lot of these diseases.
Problems.
Yeah.
Is it challenging to get doctors to come to a facility that serves the poor?
Yes and no. I think we aren't if you just read generally about us, you know, lots of docs don't necessarily see us as their home for the future in terms of providing care. But I feel like those that love our mission and love giving back and love really serving a population that really has a need, those providers are the providers that are with us for years and years.
Mm-hmm.
You know, we're lucky that we don't see a lot of turnover with our providers. Once a provider starts with us, they're with us. And it's great for the patients, too, because they have that long-standing relationship.
Right. A big responsibility overseeing a healthcare facility that has a main office and 6 satellites. What's your typical day like?
There's no typical day. Everything is new. I think for the past week or two, we've been dealing with ICD-10, new changes and transitions with the coding system, and you know, there's always something new. There's always new initiatives. There's new grants that are coming out in terms of trying to expand services. We're looking at expanding our substance abuse services now. So we see a rise in substance abuse. And so we're looking at applying for some federal funds to expand those services and expand our mental health team that targets those clients. So there's always something
When you
new.
talk about substance abuse, I mean, is this primarily among teenagers, adults? I mean, what population are we looking at?
We're still looking mainly at our adult population.
Okay.
We still don't see, thankfully, a huge increase in substance abuse among our teen population right now that we service, at least. So it's targeting our adult population.
Okay.
Yeah.
I mean, what you hear is that heroin is coming back.
Yes.
Is that something that you're seeing in a big way?
We haven't started seeing it yet. I think because our population is lots of kind of young moms and kids, we haven't seen a huge increase in our population. One of the parts of the substance abuse grant is looking at doing more kind of investigation and targeted questioning and asking and screening of our population to make sure that it's not there and we're just not catching it. So that's one of the screening areas that we're increasing.
I was interested when you were talking about, you know, the work that you did within the juvenile justice system. Were there any particular medical or mental problems that you saw there that are particularly pronounced among that population?
I would say not necessarily. It provides, you know, a same crosswalk of what we see in the general population, which is good. You know, sometimes what we do see is some of these kids we see back, kind of in our homeless populations. So typically some of the same families.
Right.
So we do see a little bit of crossover there. And so as we expect, the medical conditions kind of tend to be the same.
What's on your wish list for the floating hospital?
I think the biggest item on our wish list is a new home. So we're looking to move. We have outgrown our current space. One of the things we want to do is expand services, things like dermatology and podiatry. We want to expand our scope of services, including things like optometry also, but we've run out of space in our current clinic. So we are looking for new space within Long Island City, but because of the luxury housing market, which continues to kind of feed our patient population who can't find affordable housing, it's been difficult to find a space that really works for us. So we're looking for a new space as we go into our...
In Long Island City?
In Long Island City.
Okay.
That is, at least for our community health center, we have to stay within the same zip code because we are targeted to serve that population of clients. So we're looking to stay. And it is also a very convenient location. We're currently right by the Queensboro Bridge. And so it's a very easy, from a public transportation standpoint, for staff and even for patients to get to us. So we're looking to kind of stay in that general area.
Okay. I don't know if I told our viewers that after my freshman year, the summer after my freshman year of college, I worked on the floating hospital here in New York, and it was still floating. It was floating at the time. And while you're not still floating, I had lost track of the program, but I'm very happy to hear that you're still doing great work.
We are. We're still here. We still accept volunteers. So if you want to come out and spend time with us or anyone else does, we love to have volunteers and expose us to other people, and so that everyone knows that we're still out there.
Okay, great. Great to reconnect with the floating hospital. We're out of time. I want to thank Dr. Shani Andre, Vice President and Chief Medical Officer of the Floating Hospital, for joining us today. If you'd like to know more about the Floating Hospital or get involved, visit its website at thefloatinghospital.org. For the City University of New York and 1-to-1, I'm Cheryl McCarthy. If there are any people you'd like to hear from or topics you'd like us to explore, please let us know. You can write to me at CUNY TV, 365 Fifth Avenue, New York, New York, 10016, or you can go to the website at cuny.tv and click on Contact Us. I look forward to hearing from you.